Well, thank you so much to everybody for the invitation to be here. I'm really delighted to be on this panel. And next slide, please. So in terms of disclosures, I do have grant funding with the views I'm presenting on my own. Next slide, please. So recognition of the importance of caregiving is not at all new. We can go back, for example, to the Old Testament to see the example of Ruth, who swore to her mother-in-law, Naomi, "Wherever you go, I will go." So we see there a biblical example of caregiving. And yet, as the ethicist presenting with a group of economists, I thought maybe I should throw a graph into all of this. And the point of the figure is just to show that while we have had a very long-standing knowledge of caregiving and the importance it has, it's been very slow to pick up in the literature. And while I don't think we need a one-to-one correlation of literature on Alzheimer's disease and literature on caregiving, it's notable that we still see a substantial gap, despite the fact, as panelists today have reiterated, caregivers play such an important role, unpaid caregivers, in the care of persons living with dementia. Next slide, please. So dementia care is often managed, provided, and financed by family members. And we know that people who are facing dementia regularly worry about burdening their families. I would say, unfortunately, such worries are realistic. And I want to note two dimensions of inequity that make Alzheimer's disease relatively more burdensome. First, research shows that a dementia diagnosis poses significantly greater financial risk and hardship to typical American families compared to other illness trajectories. So gaps in public financing for dementia care are a major source of this inequity. Second, there are notable disparities within dementia care by ability to pay. More resources often equals better care, although as we heard this morning, even that doesn't mean excellent or perfect care. But we have to ask then, who does that leave behind if ability to pay is how we establish who gets quality care? So personal, medical, and financial planning absolutely cannot compensate for the various structural problems in how public insurance systems finance dementia care for older adults. And I would argue this is not only an economic problem, but an ethical problem. Next slide, please. So caregivers are the backbone of our nation's long-term care system, and David and Tisa have shared some of these statistics today, but it's, I think, worth reiterating that we have more than 11 million Americans who are providing unpaid care for people with Alzheimer's and dementia, 16 billion hours in 2021, valued at over $271 billion. And I want to underscore that a tremendous irony is that we often calculate the cost of dementia care by figuring out what these, what the market value might be of these hours. And then we hold that number out as an example of how this is a public health crisis and one that demands our attention. And yet, in the same moment, we do very little to alleviate the pressures placed on caregivers and to actually acknowledge the tremendous debt that we owe to them. Now, caregivers play an important role, obviously, in community settings, but as my colleagues at Penn, Norma Coe and Rachel Werner have recently shown in a great article in Health Affairs, they also are an invisible workforce in long-term care facilities. So I often conduct interviews with caregivers, and one woman recently told me, I didn't put my husband in a nursing home because I didn't want to care for him anymore. So they're still there, they're still providing a tremendous amount of care at the bedside, even in long-term care facilities. And I would argue that we need to recognize that the medical value of caregivers, but we also need to recognize the moral value of the care that they provide. So caregiving is not just caring for the body, although of course, when you think about the core tasks that are associated with caring for somebody with dementia, feeding, bathing, dressing, grooming, toileting, those are of course, caring for the body. But caregiving is also in dementia care essentially about caring for the mind, because it is a disease that progressively erodes self-determination. And so caregivers serve as really important repositories of knowledge about the needs of the person with dementia, as well as their interests and values. They make important decisions across a trajectory of care. When you think about, say, 8 years that somebody might be living with a dementia diagnosis, there are countless medical and non-medical decisions that they need to make. And caregivers can also serve an important role in connecting the person with dementia to their past self. So they might recognize the individual's personhood by engaging in activities like playing familiar songs on the radio, reviewing family photos, or reading poetry and short stories. And so here again, we see, it's not just the medical or the physical care, but it's really the moral value of the care that they're providing. Now, caregivers, when you talk with them, often see many positive aspects in being a caregiver, but there are emotional, physical, and economic costs associated with their care as well. And as it will be a very familiar statistic to many people in the room, a majority of these individuals are women, often adult daughters and daughters-in-law. And so this is really a gender issue. And Bruce made some great comments about the ways in which paid caregivers are disproportionately women of color. And so I think that we need to attend to matters of gender, race, and class when we think about the ethical issues that arise here as well. Next slide, please. So the pandemic was, as several people have pointed out today, really a natural experiment in what happens when care is compromised. So you take an already fragile system, you place it under tremendous strain, in a very short order, you can see all of the negative consequences that emerge. So in my own research, which was following caregivers in the pandemic for both, for persons living with dementia who are both in community settings, but also long-term care settings, we see that caregivers oftentimes had negative outcomes for themselves, including anxiety, depression. They described a loss of sense of self as they were subsumed in the caregiving role. And persons living with dementia often had worsening of cognitive and behavioral symptoms. There were increased falls, a variety of negative implications for them as well. And this was because the caregiving was fundamentally strained. For some individuals, particularly those in the community, we saw an intensification of caregiving needs when they lost formal care supports in particular, and as behavioral symptoms worsened. But for people who were caring for somebody in long-term care, we saw really an attenuation of that bond between the two, which contributed again to these poor outcomes. In talking with some of those caregivers, we saw things like people were losing weight because the caregiver wasn't in the long-term care facility to feed them. Now, one of the panelists earlier today, I think, said this really well, is that some of this was unique pandemic circumstances, but a lot of this was really just revealing how tenuous the balance is that caregivers enjoyed, even in what we might think of as normal or pre-pandemic times. And it really does underscore the need for change. Now, in framing the rest of my remarks, I just want to note that caregivers can experience role strain, which is difficulty meeting the demands of the caregiver role. And that's moderated by factors such as preparedness, the caregiver's perceived ability to meet the needs of caregiving, and also predictability, how well they can anticipate the needs of the person living with dementia. And role gain is something that they can also experience, which is a sense of personal enrichment or character building. And if we think about role strain in particular, we know it's independently associated with caregiver well-being, and it can also affect the well-being of the person with dementia, for example, because we see increased risk of abuse and neglect when caregivers have greater role strain. So what this tells us is that it's important both to mitigate the objective demands of the caregiving role, to really decrease role strain, and also to help caregivers positively frame their interpretation of the demands that are on them, as well as their abilities to meet them. But I really do want to caution here that while it's important to increase role gain, we don't want to overemphasize resilience and continue to displace responsibility on individual caregivers to persist in the face of an unjust system. Next slide, please. So in terms of some ideas for how we might address this, I would say that it really is a failure of moral imagination to perceive needs arising from dementia as solely problems for unlucky families to solve independently, and we need to have systemic solutions. And I think a lot of that is going to be organizing the healthcare system around the person with dementia and caregiver dyad. We need to think about how to do that to maximize the well-being of both parties. So in terms of a few ideas of what this might look like, we need clear documentation in the electronic medical record of who the caregiver is. We had a comment this morning about the importance of pragmatic trials and research. I'm part of the NIA-funded Impact Collaboratory, which is trying to build a national infrastructure to conduct pragmatic trials for people with dementia and their caregivers. But we often find that it's difficult to use EMRs to identify the caregiver for an intervention or outreach, making the trials less pragmatic, and this might help explain some of the difficulty we have in testing interventions and seeing if they work in practice. We need time and space for triadic communication within clinic visits. Oftentimes, we know that people with dementia feel that the caregiver the clinician talks past them, and caregivers sometimes feel excluded from conversations as well. So we don't just need extended visits or a chair for the caregiver to sit in, but we also need to have some best practices about how to engage in triadic communication. We need to think about counseling and coaching for unpaid caregivers to equip them with the skills they need to maintain the person living with dementia at home if they would choose. Skincare is one example of this, also dealing with various behavioral issues that might arise. We need interventions that are delivered by social workers to be reimbursed. These might include advanced care planning, dealing with driving, providing psychosocial support for caregivers. At the Penn Memory Center, we have an amazing team of social workers that are beloved by families, but their work is almost entirely funded by philanthropy and charitable contributions, and it's necessary to see if there are other payment models that can get these to more individuals. We need increased access to respite care because that's when caregivers get to care for themselves. We need collaborative dementia care models and dementia navigators, particularly to help with transitions. And we need to reconceptualize visitor policies to recognize that caregivers are not just visitors. They're an invisible workforce and serve as the extended mind of people with dementia. Next slide, please. Now, unfortunately, people with dementia don't all have caregivers available to help them, and individuals who are unbefriended often are particularly vulnerable to poor care and poor quality care. And I would say that the effects of being unbefriended really reverberate throughout the individual's life, not just in healthcare settings, but can also affect things like being placed in a guardianship, which is also often seen as suboptimal. And more research is really needed to understand how to care for individuals who are unbefriended, as that has not been well figured out yet. That interventions for people without natural supports. Next slide, please. So in conclusion, it's really essential to develop policies and interventions that center care structures on the dyad, and that should promote the well-being of both the person with dementia and also the well-being of the caregiver, because those two are so intertwined. Public policy needs to reflect commitment to providing services and supports that are needed by members of society who are living with dementia or delivering dementia care, and it should aim to mitigate inequities and injustices associated with this diagnosis. Thank you.